Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is a case of recurrent herpetic keratitis. This is a 65 years old female lady who had chronic history of recurrent attacks of herpetic keratitis, presented to emergency with pain and redness in the eyes, decreased vision. Her vision has decreased to the 20 by 200, and intraocular pressure was almost 20. And if you see at her initial picture here, you can see that there is extensive scarring of the cornea because of repeated attacks. And the cornea has developed new vascularization from different quadrants. And there is a centralized corneal ulcer, which is almost 2 into 1 millimeter in size. This is another corneal photograph. Here you can see that it is a centralized local corneal ulcer measuring 1 into 2 millimeter thickness, size, and taking stain. CDL was negative, no perforation, and there was inferiorly, you can see vascularization, superficial vascularization, which was crossing the limbus. And this is basically a classical case of recurrent attacks in a patient because of herpes virus. So as I mentioned earlier, she has a chronic history, and at presentation in emergency, her vision was 2200, pressure was 20, and this was the picture over there. So because of her history and appearance, it was a straightforward diagnostic case of herpetic keratitis, recurrent. And actually, these are virus has a tendency to be latent in the trigeminal ganglion. And once it stays over there after infection and under appropriate circumstances, it gets reactivated, and from trigeminal ganglion it again comes anterograde to the cornea through ciliary nerves, ophthalmic nerves, and infects the cornea. So these repeated episodes continue in these patients. So if you see the ulcer, that it is centralized deep ulcer and stromal scarring and the new vascularization, that the stromal bed, you will say that the ulcer bed is grayish in appearance because of scarring and repeated attacks, and the borders, well, you will see that the epithelium is swollen over there. This case is not giving a typical picture of dendritic we talk about, in which there are terminal bulbs and like these things, but you will see the corneal edema, stroma over there, rolled margins at the corneal ulcer. So the diagnosis is straightforward because of the history and appearance and clinical examination, and the corneal sensitivity is decreased in this patient. But if you want to go for confirmation, we can go for PCR, a polymerase chain reaction test, and this test can be done as uniplex, conventional one, and if facilities are available and a little bit expensive, that is quantitative PCR multiplex can also be done, which has an edge over uniplex, the conventional one. So when we start about the treatment of these patients, first of all, we have to go to debride that area 2 millimeter around the margin with the cotton sponges to take out that virus which is laden over there. This has also got a therapeutic effect. It decreases the viral load, it freshens up the margins, and helps in the healing also. So we started this patient on topical ganciclovir, that is 5 times a day for 14 days, and oral acyclovir 400 milligram 5 times for 14 days with cycloplegics. And for secondary bacterial infection, we started moxifloxacin eye drops. After initial treatment for 2 weeks, once the things starting healing, the lesion starts healing, we go for the maintenance tapering dose of the topical again cyclovir, because this patient has a history of recurrent attacks. So we go for the 8 hourly again cyclovir for 2 weeks topical, and after 2 weeks once daily for 2 weeks more. While oral, after 2 weeks, rather than 5 times per day, we come towards 400 milligram 12 hourly as a maintenance dose, and after 1 month it can be further reduced to 400 daily, depending upon the response, depending upon the condition of the lesion. So once we start the antiviral medication and we are continuing that long, we have to keep an eye on the renal function test, urea and creatinine. And also that once this corneal ulcer has healed and the scarring is all over there, as we can see, so we have to wait for the inflammation to settle down. And once inflammation settles down, then we can think about the visual rehabilitation. But if this ulcer does not heal, we can, or it's going towards perforation, to non-healing ulcer can be handled with EMTs. But once it has healed this one, then we can continue with our plan for the penetrating keratoplasty, that is visual rehabilitation. And for that, first of all, we have to handle these new vascularization, because if we do not control this new vascularization, the chances of rejection of penetrating keratoplasty is 30%. That new vascularization can be controlled with monopolar diathermy, and after that, once a patient is stable for at least 1 year, there is no more recurrent attacks and is stable, then we can discuss with the patient about the possibilities of penetrating keratoplasties. So penetrating keratoplasty can be an option for visual rehabilitation later on, but the thing is that even after this keratoplasty, there are chances of viral infection. That is 1.18%. And the roots are that the intracorneal multiplication of the virus can happen because of the reactivation in sensitive ganglia. The second mode is a reactivation from residual cornea, or the third, which is not that much, if the donor corneas are properly scrutinized, but that is also a possibility that donor-recipient transmission can happen. So even after keratoplasty in such patients, we have to keep it under the cover of antiviral medication. So this was a very interesting and challenging case which I wanted to discuss with you, the patient with recurrent attacks. And these recurrent attacks usually get aggravated under the time of some stress, emotional stress, or some time of weather change, or basically when the immunity is compromised. This virus, which is lying over there in trigeminal ganglion, it goes again into the cornea and activates and shows up its manifestations. So this was the case which I wanted to discuss with you. I hope you will like the presentation and it will be beneficial for you for the learning purpose. Thank you very much for your attendance and for your attention. Thank you.